In this video, I'd like to go through my approach to shoulder MRI, an approach that I think is efficient as well as thorough. What we'll do is go through the different pull sequences that we do in the typical order that I look at them. At Stanford, we do coronal T1 and an intermediate proton density T2 weighted image with fat sat, sagittal T1 and T2 fat sat, and axial proton density and gradient echo images. And what I'd like to mention up front is that there's a useful site called xrayhead.com that has labeled anatomy, and you can use that to look at T1 weighted images in the axial plane, the oblique coronal plane, or in the oblique sagittal plane, and it's useful to have a reference like this when you're going through cases on your own, and especially if you're learning the anatomy. Just a word about imaging planes. They are oblique coronal images, so if we look at the transverse scan here, axial proton density scrolling down and then back up towards the top here, and if we go to the mid-glenoid level, you can see that the coronal obliques are perpendicular to the glenoid face and humerus here to lay out the rotator cuff, whereas the sagittal images are perpendicular to the coronal images and they're parallel to the glenoid face, so they really lay out the rotator cuff anatomy nicely. When I look at the coronal images, I focus on several different things and try to get as much information as I can before moving on to the other planes. It's an analysis of the bones and the bone marrow, the acromioclavicular joint, the glenohumeral joint, humeral head, and glenoid. You also want to look for fluid in the subacromial subdeltoid bursa or in the glenohumeral joint to see if there's an effusion. And then we focus our attention on the supraspinatus and infraspinatus portions of the cuff, as well as a little bit on the other cuff tendons. It's also a great plane to look at the superior labrum and biceps anchor coming in to start get an idea of what's happening with the labrum and biceps complex, and also take a look at the cartilage. So here I've put up those coronal oblique images, the T1 weighted image on the left and a coronal T2 fat suppressed image on the right. And as we scroll through, what I start looking at is the bones and joint, the acromioclavicular joint here, the acromion, distal clavicle, look at the humeral head, looking for the shape of the bones, looking for osteophytes. Pay good attention to the glenoid because if there's a fracture, you may be able to detect it best on this plane. And the corresponding T2 weighted images show the same anatomy. Nice evaluation of the bone marrow. And we can start to get an idea if there's fluid in the subacromial subdeltoid bursa. This patient's fairly normal exam, but they just have a trace of signal in the bursa, a small amount of fluid in the glenohumeral joint here. After the bones, I focus my attention mainly on the rotator cuff. And so if we start anteriorly, and one way to remember that you're anterior is if you come further forward and you see the coracoid process, you know that's an anterior structure. If you look at the coracoid for a minute, you can see the coracoclavicular ligaments going up towards the clavicle here. We also see part of the coracohumeral ligament in here coming across. So for the supraspinatus, what I like to tell people is it looks kind of like a porpoise with the body of the animal here and coming out towards the nose here. And it's rather horizontally oriented. You have muscle here, all this gray, with tendon as the low signal structure coming out to the greater tuberosity of the humerus. What we should see is low signal throughout the tendon on a T1 weighted image as well as on a T2 weighted image. This patient may have a mild amount of tendinopathy because it's a little bit intermediate signal on the T1 weighted image. It's got minimal increased signal on the T2 weighted image, but no evidence of a discrete tear. So we go back and forth scrolling through the supraspinatus, and it's important to make sure that you come all the way anterior to the leading edge, where here's the biceps tendon as it's coming up and around. The leading edge of the supra is in here, and you want to make sure to carefully look at that area because tears are common in that area. Moving further posteriorly, we're going to transition between the supra and the infra. And one way to realize that you've done that is if you look at the T1 weighted images, you go between the muscle belly of the supra through a fat plane here to the next muscle, which is the infraspinatus. The infraspinatus tends to have more of a rhomboidal type shape, and the tendon on the orientation of our images tends to be coming up and over like this, so it's different than the supra, which again tends to be fairly horizontal. So going back to the infraspinatus, you see the muscle belly here, you see the tendons forming. And of course what we do is we look at the T1s and go back and forth with the corresponding T2 weighted images, looking for where the tendon's located and then looking for increased signal within the tendon. It's not uncommon for the infraspinatus to have a small amount of striations within the tendon as a normal finding. So we've looked at supra and infra. As you go further posteriorly, you should be able to identify the teres minor tendon coming across here. And one way to remember the teres minor is that it's sort of below the equator of the humeral head. If you picture this as like the globe, the equator would be here, and the teres minor is below, whereas the infraspinatus is above. So that's going to be infraspinatus, that's going to be teres minor. It's definitely a good idea to look at the subscapularis on the coronals as well. And if the patient's nicely externally rotated, you can see the subscap coming across underneath the coracoid here, broad base tendon with multiple slips involved coming out towards the lesser tuberosity of the humerus. We'll come back to this in a minute, but I also like to look at the superior labrum biceps anchor on the coronal images, nicely seen on the T2 weighted images here. And you can see as you scroll back and forth, you should be able to trace the biceps tendon as it comes up and around the humeral head to insert on the biceps anchor here, superior labrum being just underneath it. If we move over to the sagittal images, again we do proton density and T2 weighted images with fat suppression. Again, the main analysis is going to be the rotator cuff, again checking the supra and the infra, looking at the teres minor and the subscapularis. Probably the best plane for looking at the subscapularis is the oblique sagittal combined with the axial images. The intra-articular biceps tendon should also be looked for on the oblique sagittal images, and you should almost always be able to see that in normal patients. So here's the oblique sagittal T1 weighted image on the left, and the oblique sagittal T2 weighted image on the right side here. And these are the same anatomy but depicted with different imaging sequences. So if I go more medially here, you can get oriented, and if you don't know what's anterior or posterior, always look for the coracoid process. We know the coracoid process is going to be anteriorly projecting here, so that's anterior, posterior, superior, inferior. And you get kind of a look at the scapular Y view here with supra, infra, teres minor, and subscapularis tendons and muscles in place here. At the level of the glenoid face, you may get a glimpse of the glenoid labrum coming around here. But mainly what I'm going to do is come back to the supraspinatus here and follow that muscle belly as it forms into tendon coming out from medial to lateral as it comes out to insert on the greater tuberosity. Once again, this patient has a little bit of tendinopathy, so there's mild intermediate signal in the anterior fibers of the supraspinatus. On the T2 weighted images, signal is generally quite low. There's just minimal increased intratendinous signal, minimal fluid in the subacromial subdeltoid bursa, or perhaps just a little bit of synovitis there. Basically what I do is I scroll back and forth on the supra and the infra here, looking for signal abnormalities within the tendons, looking for contour abnormalities, as we would be looking for to diagnose a rotator cuff tear. The infraspinatus is kind of a broader tendon here, but as you come out distally, they tend to blend together. And if you're trying to decide whether a tear is in the supra or the infra, what I do is I tend to go back and forth and try to find the plane between those and try to project that out as I come further distally, and then try to decide where the junction of the supra and infra would be most distally. In reality, it doesn't matter a tremendous amount if the cuff tear is relatively distal. It's just a good idea to get a rough idea of whether it's mainly supra or mainly infra. Now, I mentioned the teres minor before. It's sort of low yield in that it doesn't get injured that often, but here on the T1 weighted images, you can see a fat plane partially between the infraspinatus and the teres minor here. So here's teres minor on the T2 weighted image, and you can follow that out again below the equator of the humeral head. Subscapularis, this is my favorite plane for this muscle. Big broad muscle here with multiple tendon slips within it, and as you come out peripherally, you can see the subscap forming into a big thick band, and especially on the T2 weighted images, it should be very uniform in its signal intensity. It can have some little striations in it, but you shouldn't see any focal increased areas of signal within it. So that's the main search for the cuff structures on the sagittal oblique images. Other things to look at, See the intra-articular biceps tendon here coming in the rotator interval between the supra and the infra. So that's the long head biceps tendon coming up the arm in the bicipital groove up towards the superior labrum biceps anchor. Here we can see a little bit of the superior glenohumeral ligament. On many normal patients, you don't see the detailed biceps pulley structures on a non-contrast MRI. Other worthwhile anatomy and structures on the oblique sagittal images. Look again at the acromion to make sure you're not dealing with a patient with an ossacromiale. Try to find the coracoacromial ligament coming off the undersurface of the acromion and this thin structure headed over towards the coracoid process here. And it's a good idea to look at the coracoclavicular ligaments here, especially if there's signs of an AC joint sprain. Here you can see the ligaments on T1 weighted imaging and then on T2 weighted imaging here. In the axial imaging plane, we also do two pull sequences. We do an axial proton density weighted image with fat suppression, and we do an axial T2 star gradient echo image. This latter gradient echo image is particularly useful to show micrometallic artifact in patients that have had prior shoulder surgery. Kind of gives a footprint of where the surgeon has been, since we don't always have good clinical history. It can be used to evaluate the labrum and the cartilage as well. Axials are great for the subscapularis tendon. You want to again locate the biceps tendon to make sure it itself is located, and then mainly we're going to use these to look at the anterior and the posterior labrum, the capsule, and assess the glenohumeral cartilage. So here on the left is the axial proton density weighted image with fat suppression. On the right side is the gradient echo image. This patient has not had shoulder surgery, so we don't see any micrometallic artifact. Going up and down here, starting at the top, you want to try to get a glimpse of the acromion coming around to the AC joint, looking for that ossacromiale. This patient does not have one. Come down to the humeral head, looking at the shape of the humeral head, looking for things like Hill-Sachs defect, rechecking the bones, looking at the anterior inferior glenoid in case there's any bone edema or evidence of a fracture there. The gradient echoes are also useful for that. They have a little bit of sharper anatomy than the PD images. The subscapularis can be tricky. What you want to do is look for that muscle belly anteriorly as it forms into tendon, and then pretty uniform tendon coming out towards the lesser tuberosity there. And as you do that, you should be able to identify the long head biceps tendon within the bicipital groove going down the arm. This has just a little bit of fluid in the biceps tendon sheath. If you get practiced at it, you should be able to see the biceps tendon somewhat as it comes up and across the humeral head on axials, and you may catch a glimpse of this structure like this, which is the long head tendon coming over to the supraglenoid tubercle to insert. That's useful. It's better seen on MR arthrograms when the joint is distended. I'm going to zoom in just a little bit here on the labrum and try to focus on that. This one is a nice normal labrum. The labrum's a difficult subject in MR imaging. But what I do is you want to look at the anterior labrum, and so here we're anterior superior. Labrum is starting here, and it's a pretty nice triangular structure that can insert on articular cartilage right along here. It should be pretty sharp anteriorly, nice sharp corner there. And as you go inferiorly, that's where I always say that's sort of where the money is, because most shoulder dislocations are antero-inferior, and as you're inferior, it's going to be that anterior-inferior labrum that gets torn or detached. So right in here, this is the inferior labrum. We're starting to get into the inferior capsule. We'll look at that a little bit more in just a moment. Posteriorly, the labrum is often a little bit blunted and less round, maybe a little bit smaller than the anterior labrum. So here's the posterior labrum in this patient, and you see those pretty nicely on the gradient echo images as well. Other structures worth learning about. Superior glenohumeral ligament's going to be in here, not really well seen on a non-arthrographic MRI. The middle glenohumeral ligament you want to pay close attention to, maybe not because it's always that important in and of itself, but it's very easy to confuse it with the anterior labrum. In this patient, there's fluid between the labrum and this structure here, which is the MGHL. And what I always tell people is if you want to find out if something's the MGHL, what you do is you go up and down on it, and the MGHL should blend in with the undersurface of the subscapularis there. So if you can find that structure blending in, you can be pretty confident that that is indeed the MGHL. Another thing to look at on axial images that can be relevant is the coracoid process. And so here, the coracoid process is projecting anteriorly. And in normal patients, the coracoid projects at about the same lateral extent as the glenoid. So here the coracoid's ending, it's about parallel with the glenoid face. A lot of patients seem to have prominent coracoid processes that are elongated relative to this. And as that happens, they can be a setup for subcoracoid impingement where the coracoid is close to the humeral head here. Shoulder articular cartilage is perhaps a little less important or less damaged in athletes than in the knee or hip, for example, but it's good to look at the cartilage. And so the cartilage here is this gray structure here and this gray tissue along the humeral head there. You want to look for homogeneity, look for focal defects, and so on. So those are the main things that I look at on axial MRI of the shoulder. So here what I did is I put back up that axial T1 weighted image, and I have the oblique coronal T2 weighted image next to it. And so here you can see again the biceps tendon coming up through the bicipital groove, going to the intra-articular portion of the biceps tendon, to the region of the supraglenoid tubercle right in here. So again, that's the superior labrum biceps anchor. Here's the superior labrum itself. Again, no fluid is undercutting that. And as you're going through axials, one of the things that takes a little while to learn is to realize where you are in space. And often I get used to looking at them without this frame of reference, but you might decide that you want to have the coronal reference image up like this, so as you're going through the mid-humeral level, you know that you're in the mid-glenoid labrum, because there's a lot of normal variants that occur antero-superiorly with sublabral foramina and so forth that are not necessarily clinically relevant unless there's a tear more superiorly or a tear more inferiorly extending to that region. So that's one point about oblique coronal images and referencing that can be helpful. Another thing that's helpful is to know what the frame of reference is between the axial images and the oblique sagittal images, because on the sagittal images you get an idea of the clock face of the glenoid, and this patient's relatively vertically oriented, but sometimes it's more sort of anteverted, and you really want to know where you're located on the glenoid in terms of the clock face. So normally you'd have like a 12 o'clock position, and then anterior is going to be 3 o'clock, 6 o'clock, 9 o'clock. And if you look at the reference of the axial images to the glenoid, sometimes it's confusing, or sometimes you think you're more inferior than you are on the axial images, but the reality is in this patient, the most inferior image that we're seeing labrum here is in fact fairly antero-inferior along the glenoid, and that's where tears often occur. So that's an important point to keep in mind. As we finish the brief review of shoulder MRI, it's important to also think of other possible things that could be clinically relevant, and that includes things like looking for muscle edema, paralabral cysts, which are basically always going to be in the face of a pre-existing labral tear. Look at the quadrilateral space. Look at the axillary structures for things like lymphadenopathy, and remember to check the localizer scan. So for muscle edema that may be a sign of a denervation type injury, just spin across the coronal images and look especially posteriorly and at the deltoid where you may get edema within the muscles. The sagittals are great for that as well, and you should see uniform signal intensity within the bellies of each of the muscles. Sometimes the deltoid muscle has a little bit of relatively higher signal because it's closer to the coil, but if you have a quadrilateral space syndrome, you may see increased signal within the deltoid muscle as well as in the teres minor. These images are also good to look for paralabral cysts, and again, you won't necessarily be looking for one unless you've seen a labral tear, but looking along the rim of the glenoid here and along the glenoid on the oblique coronal images. Here I've put back up the coronal oblique T1 and the fat suppressed T2 weighted image to show the quadrilateral space, and with a good quality scan you can see the structures within the quadrilateral space quite nicely. Here you can see these structures going through a fat plane underneath the glenohumeral joint, and so the demarcations of that space include the humerus itself, the teres minor and the teres major, and then the long head of the triceps, which is going to be more posteriorly. So this fat containing space right there is the quadrilateral space, The vessels within it often show some hyperintensity on T2 weighted scans. If you have good image detail, you can identify structures that are not as large as the vessels, like this little thing right here. That's probably the axillary nerve coming through. It's also good to realize that you don't necessarily have to have a cystic mass lesion in the quadrilateral space to have that syndrome. You may have prior injury to the anterior or inferior capsule that causes some fibrosis and sort of indirectly or secondarily affects the quadrilateral space. The other thing you want to check on is just going through the axillary area and looking at the vessels there and the extent of the nerves that you can see. A lot of patients have some small normal lymph nodes. As the last thing, or you could do it as the first thing, you want to be sure you look through the localizer images, which will vary between institutions. This just has a few images in different planes, but you get a bigger field of view, so you want to be sure to check for things like axillary lymph nodes, or you might get a glimpse of some pathology in the chest, because of course we don't want to miss important incidental findings. So that's been a quick and somewhat incomplete, admittedly, review of shoulder MRI review. Again, what I do is I tend to look at the coronal T1s and proton density or T2 weighted images with fat suppression first, really focusing mainly on the bony anatomy and fluid and the rotator cuff, getting a glimpse of the biceps anchor and superior labrum. Refine my thinking about the rotator cuff based on the sagittal images, look at the interarticular biceps tendon, then use the axials in combination with the other planes to recheck subscapularis, biceps tendon, and the labrum anteriorly and posteriorly, and try to put the whole picture together. Finally, check in miscellaneous items. And once again, remember that you can go to xrayhead.com if you want to get more detailed labeling of anatomy. I hope this is useful to you, and I appreciate your comments, so thanks for joining me.